The topic given to me is controversies to consensus in the management of hypertension. This particular topic is more important and more relevant, not only from the point of view of clinicians, practitioners or physicians or whichever branch of medicine we belong to, but also for the point of view of the patients themselves. There has been a sea change or a paradigm shift in the last few years in the understanding of hypertension, especially the so-called classification of the stages of hypertension, the so-called selection of choice of therapy as initial therapy in the management of mild to moderate hypertension. Recently, few papers have been published which are really thought-provoking and some are controversial, and we have to draw the consensus out of these recently published papers. In the next 15 minutes or so, I would like to touch upon some of the important aspects of hypertension which are pertinent or relevant to our population. We will be briefly talking about the Indian scenario. We will spend a few minutes with regard to the correct measurement of blood pressure, which is very important. What is the role of the ambulatory blood pressure in the present scenario, and what are the guidelines from various societies like JNC8, European Society, what is our own Indian guidelines with regard to the management, and what are the recent trials that has provoked the controversy, or what is the message which we get out of it, and finally what is the role of what is the classification or the choice of drugs in comorbid conditions like patients with chronic kidney disease, patients with diabetes and hypertension, patients with hypertension and coronary artery disease. And finally, a word about what is the ideal timing of taking the antihypertensive pills. So these are some of the important issues which I have thought that we will highlight in the next 15 minutes. It is not possible to talk each and every aspect of hypertension in 15 minutes time. It takes about 48 or 72 hours, more than that, to discuss all about hypertension. So please bear with me. I will touch upon only the fewer aspects which I have just now mentioned. We always read the Western literature or Western journals or Western textbooks, but what is happening in our own country, we must be aware so that we are going to deal with our own patients in the Indian subcontinent. So what is happening here? What is the Indian scenario of hypertension? The prevalence of hypertension in India is now currently estimated to be somewhere around 29%. Now you can imagine the quantum of the problem. In a country with 1.2 billion population, 29% is an enormous burden. The burden is not only for the patients, it is for the practicing physicians, it is for the government as well. So we are facing a tremendous burden of volume, a high volume of patients with hypertension. Here you can see in this slide, it has been high not only in the urban population but also in the rural population. In other words, the incidence has been tremendously increasing in the urban population. We know because of the industrialization, urbanization, the unhealthy way of life, food, stress, and so on and so forth. Lack of physical exercise and so on. But at the same time, from somewhere from 2 to 4% in the rural population, it has gone up to 27%. So the curves are converging in the recent years. So the rural India is no more protected from not having hypertension. Just like diabetes, India is going to be the hypertensive capital of the world. When you talk about 29% or close to 30% and 1.2 billion population, definitely we will be in the top of the world, both for diabetes and hypertension. Both are silent killers as well. The other important message one should clearly understand is the prevalence is high. The proportion of patients who are aware that they are hypertensive is only 41%. Only 41% of patients are aware that they are having hypertension. That is why it is called as silent killer. Suddenly it produces cerebral hemorrhage, stroke, and patient dies. Suddenly patient develops aortic dissection and dies. Suddenly patient develops acute myocardial infarction and dies. So because of acute coronary event, acute cerebral hemorrhage, the patient loses life all of a sudden. So it is aptly called a silent killer. So in other words, many of us do not know that we have high blood pressure because it is being silent. If there are 100 people assembled here, I am sure at least 20 to 30 of them will have hypertension. The other important sad thing is, even if those patients who know that they are having hypertension, only 37% are treated or regularly taking medications. Remaining patients do not take medications or they discontinue medications for whatever reason. The third important, last important thing is, even if those patients who are taking medication, only around 20% of patients, the BP is adequately controlled. Remaining patients, the BP is uncontrolled. So this is a very sad aspect of the prevalence, the incidence, and the detection and treatment and optimal control of blood pressure in the Indian population. This is very, very sad. This is about the history of blood pressure measurement, which I am not going to elaborate in the interest of time. But what I would like to say here is this statement. Norman Kaplan, who is an authority on hypertension, said the clinical procedure of greatest importance that is performed in the sloppiest manner. He means the blood pressure measurement. So blood pressure measurement is a very important clinical procedure which has been done in a very sloppiest manner. That is why it produces a lot of errors and a lot of confusion among the physicians as well as the patients with regard to the hypertension and its management. So, the ideal way of BP measurement is mandatory. It looks very simple, but unfortunately many times we are not measuring the blood pressure appropriately, scientifically, as per the guidelines. We are not using the appropriate sized cuff, appropriate method of blood pressure. That is why the blood pressure is highly variable in the same given patient. Even though it is a dynamic phenomenon, but variability because of the measurement defect is also equally important. All of you know aware how to measure the blood pressure. I am not going to talk about it in detail, but please remember all these facts whenever you measure the blood pressure in any patient who comes to your clinic. That is very, very important. Especially the patient who comes for the first time with high blood pressure, kindly measure the blood pressure in both arms, if possible in all the four limbs. If you measure so, you will not miss a coarctation, you will not miss aorta arteritis, you will not miss any other arterial disease. And please measure blood pressure at least in sitting as well as in standing if the patient is on antihypertensive medications, so that he cannot miss postural hypotension. So, the measurement of blood pressure with correct method, correct equipment, correct cuff, correct size cuff is very, very important. This slide shows you what will happen if you do not measure the blood pressure properly, what are all the areas where the error can occur. Coming to the most talked about entity, that is ambulatory blood pressure monitoring. Nowadays, more importance is being given to ambulatory blood pressure monitoring, because the office blood pressure monitoring may not be right all the time, because the blood pressure, as I told you, is a dynamic condition. For example, when the patient is shouting or when the patient is in stress, BP may be very high. When the patient is sleeping at night, it may be 110 or over 70. So such a dynamic phenomenon. So if you want to correctly get the mean blood pressure or the average blood pressure in the patient, we have to monitor at least for 24 hours. It is especially important in patients, at least in some selected group of patients. For example, patients who are having borderline hypertension, one time it is normal, another time it is 140 over 100. Or what is called the white coat hypertension. Patient's blood pressure shoots up as soon as he enters the doctor's chamber. Isolated systolic hypertension, which is more common in the elderly. Nocturnal blood pressure. Normally there is a dip in the night in patients, whereas in some hypertensive patients, the nocturnal dipping may not be present. So that can be detected only if you do the ambulatory blood pressure monitoring. Resistant hypertension. If you want to label a person as having a truly resistant hypertension, if you want to step up the medications, you should do the ABPM. Hypotensive patients who have syncope or giddiness, especially when they are drugs like alpha blocker, if you want to know whether the symptom is due to the low pressure, then you have to do ambulatory blood pressure monitoring. So these are some of the important indications for doing ambulatory blood pressure monitoring. Of course, there are some limitations because it may be little expensive, it may be little, there may be some discomfort to the patient, but however, at least once every patient with hypertension should undergo ambulatory blood pressure monitoring. Guidelines of hypertension. As I told you, the recent few years, different guidelines are being put forward by different organizations. For example, the JNC, the Committee on JNC 8 has given some new guidelines. The European Society of Hypertension has given some new guidelines. The American Society has given some new guidelines. The International Society for Hypertension has given some new guidelines. But whatever it is, let us follow a standard or the guidelines which has been put forward by the Indian contemporary physicians and cardiologists. The optimal threshold in most of the guidelines is the cutoff is given as 140 systolic and 90 diastolic. But in certain conditions with diabetes and hypertension, chronic kidney disease, it may be around 130 over 80 or 85. In elderly hypertensive or isolated systolic hypertension, it may be a little high, like 150 over 90. Other than this, there is no gross difference. In the Indian scenario, with regard to the treatment, all of you are aware that the drugs of choice for the management of hypertension nowadays would include low-dose thiazide diuretic, especially chlorthalidone, the smaller dosage, angiotensin receptor blockers, angiotensin converting enzyme inhibitors, calcium channel blockers, and of course beta blockers. Beta blockers are not widely preferred nowadays because they are not the first line drugs as per the recently published papers. We will talk about it a little later. The Indian guideline says younger patients, in step 1 hypertension, younger patients, one can use ACE or angiotensin converting enzyme inhibitor or ARB or beta blocker if there is a specific indication. Where we can use beta blocker, patients who have hypertension and ischemic heart disease, who have angina, one can use beta blocker. Patients who have hypertension and sinus tachycardia, where you want to control the heart rate, you can use beta blocker. High renin hypertensives, highly anxious, stressful hypertensives, you can use beta blocker. Otherwise, there is no specific role for beta blocker in isolated hypertension. The older patients above the age of 55, as per the guideline, you can use calcium channel blocker or low dose thiazide diuretic. In step 2 hypertension, again younger patients, A or B within brackets. In older patient, C or D. In step 3 hypertension, A plus C plus D. That is angiotensin receptor blocker, calcium blocker, diuretic. In resistant hypertension or step 4 hypertension, you can use, along with drugs, you can use either alpha blocker or spironolactone. When I talk about beta blocker, nowadays we prefer to use selective beta blockers like vasodilating beta blocker like nebivolol, especially in patients with coronary artery disease, or in patients with heart failure, one can use carvedilol or bisoprolol. Otherwise, by and large, beta blocker as a step 1 or a first line drug in uncomplicated hypertension is no more recommended. You have heard about the polypill and the Indian scenario when the compliance is poor, when the patient has to take multiple drugs. When you want to give a cost-effective and good compliancy, you can use this polycap or polypill, which has a beta blocker or ACE inhibitor, statin and antiplatelet drug like aspirin. Some studies are being conducted and we are waiting for the TIPS 3 trial with regard to the use of polypills. Chlorthalidone is more widely used nowadays than hydrochlorothiazide. The reason being, chlorthalidone is longer acting, and the latest studies, especially the ALHAT trial, has shown that the long-term outcome is better. Only thing is, we have to use in a smaller dosage, like 6.25 milligram once a day. So it is found to be superior to hydrochlorothiazide. So in mild hypertension, uncomplicated hypertension, one can start on with chlorthalidone. In moderate hypertension or stage 2 hypertension, it is always better you give combination of drugs rather than giving single drug in the higher dosage. Kindly combine 2 drugs. For example, either you can combine ACE with diuretic or ARB with a diuretic or a calcium channel blocker like amlodipine with a diuretic and so on. So moderate hypertension or stage 2 hypertension, straight away start with combination therapy. That is always better. Why the beta blockers have been pushed to the back seat? What is the reason? It is mainly because of the recently published studies. For example, I just got 2 studies where the beta blockers are given a lesser importance due to the following reasons. One is the life study, where losartan was more effective than atenolol in reducing the cardiovascular morbidity and mortality as well as all-cause mortality. So after the publication of life study, people preferred ARB over atenolol. So atenolol is not widely used. It has been pushed to the back seat almost or given up. The other study is the Ascot BPLA study, in which the fatal and non-fatal stroke, total cardiovascular events and procedures and all-cause mortality was lower in amlodipine-based regimen than atenolol-based regimen. So in this study also, calcium blocker was found to be superior to atenolol. So based on these studies, the atenolol is not that widely used nowadays. Maybe because these drugs do not give a favorable cardiovascular outcome, or they do not reduce the so-called central aortic pressure. Central aortic pressure is more often talked about, which is more important for the vital organ perfusion like brain, coronaries as well as the kidneys. So because of that, atenolol is not doing well. The other important aspect is in the Ascot BPLA study, in the subset of patients they found that there has been 31% new onset of diabetes in patients treated with atenolol group. So new onset diabetes is found to be more in patients who have been treated with atenolol group. We do not know the reason. Maybe it is something to do with the insulin receptors. So because of this, beta blockers are not the preferred agents of choice as a first-line therapy in the management of isolated hypertension. What about the recent trials published in 2016, especially the New England Journal of Medicine? There are two. I would like to quote two important trials. One is the very famous trial called the SPRINT trial, systolic blood pressure intervention trial. Here the primary hypothesis is CVD composite event rate lower in intensive blood pressure control. But intensive means the systolic BP is reduced to 120, the diastolic is reduced to 80 in non-diabetic patients. So very aggressive treatment of blood pressure in this group. And the primary outcome is myocardial infarction, acute coronary syndrome, stroke, heart failure and CV death. There is a significant reduction in all-cause mortality as well as almost 25% lower risk of primary outcome. This is a very important observation by these investigators, and the side effects like hypotension, acute kidney injury is not statistically significant when compared to the standard line of treatment where the target blood pressure was kept around 140/90. So the SPRINT investigators concluded that treatment effect similar in all 6 pre-specified groups of interest, namely the age, sex, race, baseline BP, and history of CVD, history of CKD. The overall benefits of more intensive BP lowering exceeded the potential for harm. In other words, the outcome is better if you maintain the blood pressure somewhere around 120 systolic and 80 diastolic. It's a very important landmark study where aggressive blood pressure lowering is useful, but it is a subject for debate and controversy. But one important observation I would like to quote here is, how did they measure the blood pressure in this population? What they have done was, it was not measured with a physician in the clinic. The patient was seated in a quiet area for 5 minutes, then BP was recorded by a commercially available automated unit that records 3 readings separated by several minutes with no clinician or no nurse. It is something like a self-measured blood pressure, so there is no white coat effect. So that is how the SPRINT investigators have evaluated these patients. This point has to be noted. Why I am telling is, this may be different from what we record in the office by the doctor himself. The other important trial, which is almost controversial to SPRINT trial, is the HOPE 3 trial, which was done by Salim Yusuf and his co-workers from Canada, which is also published in New England Journal of Medicine. In that, they have studied the same type of patients with BP around 140/90, and they have used placebo versus candesartan and hydrochlorothiazide, and they found that there is no significant in the difference in the cardiovascular events. This is a controversial point, but here this BP was measured by the physician office. So, what is the fact? What should be the fact? Is it 120/80 or 140/90? The fact should lie in between. Because in sprint investigators, they have eliminated the white coat effect, whereas in our practice, we measure the blood pressure by the physician or by the nurse. So it should be somewhere around 130/80 or 90. It may not be as low as 120/80. And the future studies will tell us what is the target blood pressure in our patients, whether it is 120 or 130 or 140. Till then, we have to keep our fingers crossed that we have to treat up to 140/90 and wait for the results to come. But in patients with diabetes and hypertension, it is better to keep the blood pressure on 130/85. And also in patients with CKD, chronic kidney disease, better to keep it around 130/85. Diabetes with proteinuria, it is all the more important that you have to manage the blood pressure stringently. So patients with diabetes with significant albuminuria, it is better to keep the BP around 130/80. Chronopharmacology, that means what is the ideal time to give the antihypertensive pill? Is it in the morning or in the evening? Again, this is a controversial subject. Some studies have shown that if you give it in the evening, then you can prevent the early morning surge of blood pressure and the cerebrovascular and cardiovascular events in the morning hours. But still, many studies are going on, large number of patients are being included, but the results are not yet published. Till then, in our practice is either you give, if you want to give one drug, you give it early in the morning, as soon as the patient gets up, so that the morning surge of blood pressure can be prevented. If the patient is receiving two drugs, for example, if the patient is receiving one ARB and one CCP, you give one drug in the morning and one drug in the evening, so that the 24-hour control of blood pressure and the early morning surge can be prevented. So to conclude, ladies and gentlemen, hypertension remains a condition of public health importance in India. The prevalence is very high, both in the urban population as well as in the rural population. Many patients are not aware that they are hypertensive. Even those who are aware, they are not taking the medications. Even those who are taking medications, in many patients it is not optimally controlled. That is the Indian scenario of hypertension as on date. Methodology to measure blood pressure is very important. We should measure blood pressure with appropriate BP apparatus without any error. Ambulatory blood pressure is useful in certain conditions associated with hypertension, like nocturnal dripping, resistant hypertension, white coat effect, and so on. Although recent trials have provided some information, some trials have given you some contradictory target levels, which we need to wait for some more trials to come to consolidate our ideas. BP goals can be lowered further in some special population. Just like LDL cholesterol, lower the better. In hypertension also, in future may have lower the better. Choice of drugs, as I told you, low dose thiazide like diuretic, like chlorthalidone, angiotensin receptor and angiotensin converting enzyme inhibitor, angiotensin receptor blocker, calcium blocker, especially long-acting calcium blockers like amlodipine or cilnidipine may be used. In resistant cases, one can add alpha blocker or spironolactone. Beta blockers are not widely used nowadays because I told you the reasons. If you want to use beta blocker or whatever indication, you can use vasodilating beta blocker like nebivolol, or in heart failure you can use Coimbatore or bisoprolol. Till more data emerge, evening dose or morning dose, whatever is suitable for the patient, if it is early in the morning or late in the night, if the two drugs are used, you can give one in the morning, one at night, so that 24 hours BP control will be there. So with this, I would like to conclude my lecture. I once again thank you for your kind attention. I thank the organizers once again for the opportunity. Thank you very much.